in the development and implementation of highly active antiretroviral therapy as the modern standard of care for HIV disease. He then pioneered treatment as prevention, or TASP, which you're going to hear a lot about today, using antiretroviral therapy to simultaneously stop progression of AIDS and death and HIV transmission. And then based on this TASP strategy, he has gone on to explore other diseases and other settings where this might be useful. And so I look forward to hearing that from him. And I'm not going to take any more of his time. So, Dr. Montaner.
Thank you, Bob. Thank you all for coming today. I was just briefly telling my colleagues I'm planning to share with you a little bit of the history of what we've done over the last 4 decades to control HIV/AIDS and set the stage to, in a further discussion, maybe some months down the road, to tell you how we're planning to expand this into other areas of medicine and public health work that is currently underway. I'll just leave you with a sense of where we're going today, but that will be the subject for another conversation. As Val indicated, I'm going to talk mostly about treatment prevention in the area of HIV/AIDS and how this came about from our perspective. This is going to be very biased. I'm not intending to give you an encyclopedic review of HIV/AIDS literature over the last 40 years, but rather what we saw, what we did, and how we brought it to under control. Val alluded to the land acknowledgement, as we routinely do, and I decided to, rather than duplicate that effort, to share with you the fact that we are living in very unprecedented times. As you know, very recently, the CMA, the Canadian Medical Association, formally apologized for systems past and continuing harms to Indigenous peoples in this country. And I must confess that I thought Argentina was singularly bad the way we treated our Aboriginal people, and sadly, I think we're all in the same boat. I think this is a very important first step towards amending some of these fences. From my part, I'm happy to tell you that a lot of the work that we've done impacts disproportionately First Nations, and as you will see, the outcomes have been uniformly good regardless. So that's something that we need to be very proud of. Okay. Allow me to make this very personal. I was actually finishing my training in Argentina when I met Jim Hogg at a conference in Uruguay. Jim Hogg, for those of you that don't know, was the person that started academic medicine in this institution back in the 70s. He was recently relocated here from Montreal when I met him, and we engaged in a conversation. I had no idea who he was. Otherwise, I would not approach him. And we just started talking about some of the research that he was doing. And in my usual way, which Barry may remember, I started challenging this and challenging that, and all, just for the fun of it. And eventually he said, some of those ideas are very good, and I'd like you to come over and try them in Vancouver. I said, no, I'm not interested. My objective is to move forward in an academic career in clinical medicine. I'm interested in respiratory medicine, but what you do is animal experiments, and I'm not interested. He looked at me and he said, I think you're making a mistake. The best people in the field that I am familiar with have all done basic science, and no matter how little or how much you do of it, at the end of the day, that will give you a very solid foundation. And you'll see that when you look at a patient, whether it's an X-ray, CT scan, a pulmonary function test, you will be seeing through that stuff that you didn't even appreciate it if you were just clinically trained. I say, yeah, sure, no problem. That was me in my 20s. And I haven't changed that much. And so I walk away and I say, yeah, sure. And he said, no, listen, this is my name, my address. So if you change your mind, let me know. I walk around the conference. I met somebody that was very prominent, a friend of my dad. My dad, by the time, was a senior academician, dean of medical school, a whole bunch of stuff. So I was really eager to go abroad to gain further qualifications so I could go back and work with my dad one day. And my dad was not at the conference, so I checked with his second in command, and the guy says, "Do you realize who you were talking to?" I said, "I have no idea." I said, "Well, this is the guy that described the site of obstruction of the small airways in COPD." I said, "Oh my God." Yeah, he said, he was in the New England Journal of Medicine, I don't know, last month, or whatever. And I thought, well, it's so what? And, they started to brainwash me. By the end of that night, I was sort of shaking and confused. And the next morning, not having sleep all night, I approached Dr. Hogg and I said, Jim, I wonder if you will reconsider. He did. And so in 1981, I came to Vancouver to do pulmonary research in the pulmonary research lab, which is currently what we know as, what do we know as now? Heart-Lung, the Heart-Lung Institute. Anyways, the first few years, as I was training, I got engaged in pneumocystis pneumonia work, and we did very well. We saw a bunch of things totally different than other people, thanks to Jim's influence. And we pioneered the use of adjunctive corticosteroids for the treatment of pneumocystis pneumonia, both mild, moderate, and severe. In fact, Silvia Guillermi was my fellow for a time at that time. And we proved that could work, and we could then develop prevention treatment for PCP. And guess what? PCP was gone. But people were dying nonetheless because the underlying HIV disease continued to progress. And being the stubborn person that I am, I took that personally, and I decided to change the focus of my career to develop antiretroviral therapies. That was around the time that John Rudy had been approached by the federal government to invite us to develop a clinical trial to test ACT, the first candidate drug that became available in 1986. And I was basically first in line and said, yeah, I'll do that. So Karen Gelman and myself were tasked to organize an ACT clinical trial. Don't worry, it's not here yet. And in those days, what we could do is study the safety of ACT monotherapy, which the only drug that was. And although early returns from clinical trials were positive, the truth is that the effect of ACT on people living with HIV were short-lasted, often, if not always, associated with the development of resistance, and eventually the treatment would fail and people would continue to progress. However, my dad was a TB doctor, and I spent lots of time, learning from him and gaining further inspiration from him. And so I remember at that time that he said to me in one of the many conversations, how in 1956, the year I was born, and he was basically in my same level at that time that I was now, when I was playing with the ACT new candidate. And he said, look, back in the day when you were born, I was called to the office of the boss, and he said, Julio, my father was Julio Sr., says, Julio, here I have a lot of a new drug, streptomycin. I would like to try it in the ward and see what happens. That was clinical trials in 1956. So my dad, who was one of the youngest guys in the team, went into the ward. He didn't know what to do with it, but safety above all. So he found somebody that was going to die with meningitis, secondary to severe tuberculosis, a young woman. She was comatose, so there was no hope whatsoever. And he said, well, at least I'm not going to hurt anybody. At least that's what he thought. So he gave the streptomycin to this person. And lo and behold, this woman who had no chance to waking up, woke up, was able to talk, was able to walk, and it lasted about a month. Unfortunately, she deteriorated and she died from her tuberculosis. And it took them a long time to figure out that the reason for that was that the streptomycin, while it was a very powerful antimicrobacterial, it also had a very low genetic barrier to the development of resistance, and so resistance would develop very quickly. And so that's where the notion of adding antimicrobials or antimicrobacterials onto the regimen started to emerge. And of course, that was not my dad's contribution, but among others, they explored this and it worked. And so lo and behold, I used that as an inspiration. ACT worked for a short period of time, but it didn't last. I thought, well, let's see what happens if we do 2 drugs as opposed to 1. And with 2 drugs, we got a better response, but not good enough. But we were seeing that the development of resistance was actually postponed if you were taking more powerful antiretroviral therapies. And so, lo and behold, I started to travel the world to try to find a 3rd drug that could be a suitable candidate for our work. And, being a young Latino, and I was very young, from Canada, I got 0 traction whatsoever. But as it happens, the Americans did a couple of trials with a new drug, nevirapine, that in vitro have given good results, except that those results were actually withdrawn within a matter of weeks. This was a Harvard group, because they realized that their claims were a function of the in vitro artifacts and not real effect of the drugs. And I'm not going to bore you with the details. And then the California group that Richmond and Diane Havler, they finished a study with this drug, nevirapine, and they showed that unfortunately this drug behaved like a streptomycin, even when they gave it in combination with antiretroviral therapy, meaning that patients would have a good response, but it would be short-lasting. So I was friends with the NIH scientist that was now working as the lead for the Boehringer Ingelheim company that owned nevirapine. That was a family-owned company. And so she said, Julio, I really like your idea. I wanted to try 3 drugs de novo in people who are not treated, so that we would not create a situation where we prime the virus to 1 drug, A, B, and C, and therefore we don't get the full effect of the viral suppression. So she came back from Europe, and she says, the family has decided that they're not going to throw nevirapine into the garbage. You have the last chance to resuscitate it. If it works, it's in. If it doesn't, we throw it to the garbage. I say, okay, that's a small challenge. So I organized my first international clinical trial in the yellow panel that you see there. And that was happening at the same time that we were organizing the Vancouver 1996 International AIDS Conference, which we really secured in the early 90s. In 1994, Joe Average, a patient of mine, still today, did this painting to represent the conference, etc. This has become a rather iconic figure. And the theme of the conference we crafted as One World, One Hope. We knew there was one world affected by HIV. We had no idea that there was a hope, let alone the fact that the hope was actually doing in our laboratories here. Lo and behold, the triple therapy regimen showed that it could, in adherent patients, could fully suppress viral replication. People could recover and actually lead a near normal life. The beauty of this was that at the time that we first came up with these results, there was no technology to measure viral load. Viral load didn't exist. But I was lucky that we were friends with John Sinitsky from Roche Molecular Systems in Sacramento, in California. And they have developed a PCR assay to characterize the amount of virus that a person had in their blood, except that they didn't know what that assay would implicate or show or prognosticate. And so he gave me a bunch of kits. He said, Julio, you have so many trials and cohorts, whatever. Why don't you try this in one of those studies and see if you can help us to understand what does it mean? So by late December 1995, the virologists that were doing the studies, the secondary virology assessments for us, was doing viral cultures. And he calls on me and he says, look, Julio, the ACT-DDI nevirapine study is not working. I cannot grow the virus. And I said, well, could it be that the treatment is working beyond our expectations? I said, no, that never happened. It's true, it never happened before. You could not actually shut down the virus with the tools that we had at the time. You could slow the growth of the virus, but time to positivity was a matter of days or months or whatever, but it would always happen. And so I said, look, please don't panic. That was but it doesn't matter. The issue is that I came back home, I looked at everything that we were doing in the laboratory, and I told my laboratory staff, let's run all of the samples, separate aliquots, using the PCR assay that we don't know what it is, but let's see if we can get a signal. And so with blinded data, we got these 3 curves, and I didn't need to unblind the study. You could tell immediately, even when we knew about the drugs, that the intermediate suppression was ACT and DBI because they have lower likelihood of development resistance when given together. ACT and nevirapine failed just as they did in California. And when you give the three of them, you see a profound drop in viral load. But more importantly, if you stratify by adherence, the people that were adherent to the regimen, they were actually 100% suppressed, and they remained suppressed for a period of time. Trip Bullock, a few months later, at CROI, showed in 1996 that triple therapy using a protease inhibitor, in this case indinavir, ACT, and 3TC, would achieve a similar response. Indinavir has a lower threshold, a higher threshold to develop resistance. That's why you see that this is more durable. Before we were able to counsel people that in order to have a full effect with these drugs, you had to be very highly adherent. And so, lo and behold, we got together, we created a new set of standards, and even though the assay was not even approved or tested or anything, we said everybody has to have a load. We moved that forward, and the rest is history. At that time, we had a very good relationship, and we still do, with the provincial government. So we went forward, we shared with them the recommendation, and immediately we launched triple therapy, so that by 1996 already, death in the program were dramatically down, life expectancy was growing, and to be honest with you, we're very happy, except that all of a sudden we saw something interesting, and that was that at a time in which there was no expectation that the antiretroviral therapy could render you non-infectious, we were seeing that in the context of ever-growing syphilis within our midst, we saw a deficit on the number of new HIV infections diagnosed in the province at a time in which syphilis demonstrates sexual practices were not really changing favorably. And on top of that, around this time, we had an explosive spread of HIV in the downtown east side. So something was stopping HIV, and it was not really a change on behaviors. And we stipulated at the time that this could be a function of the people on treatment. And so very early on, we proposed a hypothesis that by treating people adequately, you would be subtracting them from the donor pool of people infected with HIV. And so if that was the case, we argued that there could be a proportionality between the number of missing HIV cases and the number of people that were on antiretroviral therapy or virologically suppressed on antiretroviral therapy. We were fortunate enough to be able to access international data sets that allowed us to test that hypothesis in the north and the south of the world and everywhere else, and where we were able to show the same degree of concordance between the number of people on treatment being proportionally or inversely related to the number of infections or the number of infections that were disappearing. We put it together, we sent it to the Lancet, and despite some back and forth, in 2006, this became a viewpoint article in the Lancet, just at the same time that I was invited to present state of the art at the Toronto International AIDS Conference in 2006, where I basically was able to show this to the rest of the world. It was very controversial at the time because, as I said, people who were on antiretroviral therapy who had donated a kidney or had given a transfusion or something of the kind, you would always had the virus coming back. But in the setting of whether it's sexual, needle, or even vertical transmission, antiretroviral therapy eventually proved 100% effective to shut down transmission. Very early on, we were interested on expanding this kind of work at a sort of with a public health intent to make a difference at the populational level. And in order to do that, we need to understand the economic benefit associated with this so that we could actually rank it, if you want, within the various priorities within the public health system. And so what we did at the time with Carissa Johnson, that was a student with us, and Adrian Levy, who was an economist working with us at the time, we basically said, well, let's see if we can calculate the return on investment associated with patient-centered impact of highly active antiretroviral therapy. That's a dashed line that you see here. Now, I'm not an economist, neither are you, so don't worry about it. All you need to know is that if you have a treatment that is underutilized and that is very highly effective, and you ask the question, what is the return on the investment associated with expanding that treatment to a larger population, you will always get a sigmoid curve, as you see here. And the shape of this curve is informed basically by the effectiveness of the intervention. In this case, we're saying this is 100% effective. You can dicker with that, but doesn't matter, it's a model. And so we say, listen, this is highly effective, good. And then the second parameter that is important is what is the age of the cohort where you are putting this intervention to work at the time of inception. Why? Because if you're in your 30s here, you only have a limit of 35 years to generate return on investment based on the nature of the calculation. And so economists basically would argue that after a certain age, we are not contributing economically anymore, which is their bias, but that doesn't matter. And so this is what you get. What we really wanted to know is what happens when we add to the patient center, this is morbidity, mortality, basically, benefit, the transmission benefit, which means the fact that now you treat me, and therefore my wife, my partner, my friend, my whatever, they don't get infected. And so what happens is that you see a change in the shape of the curve. This is what we, at the time, called a game changer. And it's a game changer not because it changes anything but the shape of this curve. And why is that important? What is a game changer? Well, very simply, because if you're competing within the current environment, every single intervention that you have is going to have a return on investment that looks like that. But if you find an intervention that at the same time that stops morbidity and mortality, stops transmission, what happens is because you block my transmission to 1 or 2 or 3 or 4 people, you are basically blocking their transmission to their next 3, 4, 5, or whatever partners. And so this curve, the more we transmit, or potentially, the steeper it gets. And so in reality, what it says is that you need to invest massively. And you know, we often say, no, this is a bad person because the social behavioral characteristic. Those are the people that we are most interested to engage because these are the people that die this curve higher and higher up or the slope higher and higher up. Keep that in mind because that's going to inform everything else that we've done ever since. And to show you how that works in the community, this is a modeling exercise from my good friends, Ruben Granich and Brian Williams, with whom we have collaborated over the years. And what they did is that they show the impact of treatment prevention in terms of saving lives in South Africa, going from very late treatment, when you have age or a CD4 count of below 200, to a CD4 count of 350 regardless of symptoms, to a CD4 of 500 regardless of symptoms, or to a treatment for all, test and treat or treatment prevention on the blue line. And we can see is that basically the more you treat, the more lives you save. But on the other hand, you see here the return on investment, the more you treat, the more you spend, but despite that is associated with the early implementation of the program, only lasts somewhere between 5 and 10 years, depending on how rapidly you deploy it. And then invariably, it crosses the baseline, and now you're laughing all the way to the bank. And why? Because you're preventing infections, not just morbidity and mortality, but also new infections. And so if you treat massively everybody in South Africa, for example, you will be saving in the order of 30 billion. And this is the kind of analysis that helped us to move these arguments forward. I'm not going to go into the details. This is BC data. It's not as pretty and it's not as acute in terms of how it rises and whatever, because the scales are different, the volumes are different, everything is different. But it doesn't matter where you do it, whether you do it in the south of the world or the north of the world, the profile that you see is exactly the same. So how do we actionate these or implement these in a populational environment? We eventually landed on an approach that is driven by the cascade of care. And so what we did basically is we went around the world and we met with people from all walks of life that were interested in the HIV/AIDS issue. And we started asking, what does it take for a person that is at risk or infected with HIV in your environment to go from there to fully suppress all the time, biologically suppress, that is. And people would say, well, they need a subsidy to take the bus, or they need this, or food, or shelter, or this, or that, or to be diagnosed, or to start treatment, everything. And we put everything in a sequential, and this is just an example, in a sequential kind of way. And then what we did is we started exploring what we could do to make this cascade, this series of steps that you see going down, down, and down, to actually make this more of a lake, all flat up here. So what the idea is, how do you make 100% of the number of people at risk for HIV infection to be diagnosed, to be treated, to be suppressed? And so if that's the case, this would be a flat line over here. Now, you don't go from here to here overnight, but as you can see in a paper that we published a number of years ago, every year, for the most part, we saw an improvement in the cascade of care, and some steps better than others, but over time, using this approach, we were able to interrogate our own data to say, well, what can we do to improve what is going on between the purple and the green and whatever, and that's the way we move forward one day at a time. Eventually, we managed to get everybody more than 95% suppressed in the province of British Columbia. I'm not going to talk about PrEP in any detail, but I need to make it clear that since 2018, when Adrian Dix became the Minister of Health, we were able to secure his support to bring PrEP to the province. This program has been extremely successful. It enrolled very quickly, as you see here. And currently, we have something in the order of 6,000 patients or more on the PrEP program. PrEP is pre-exposure prophylaxis. It involves Truvada, for the most part, which is FTC and tenofovir, all combined in one pill. You take one pill once a day for the rest of the time that you are at risk for HIV. And if you take it routinely, daily, with that, perfect adherence, the likelihood of you contracting HIV, even if you become exposed, is as close to zero as you can expect. So what has all of this done for our epidemic in British Columbia? Well, the first thing that I always like to focus is in HIV-AIDS-related mortality, which is the real reason why we started all this program. And what you see here is that the mortality, for which we have data starting in 1982 when the BCCFE was established, it was already quite high. The epidemic here started in the first half of the 80s. So this basically went up like that. Here it goes to the peak. Notice that the peak started to come down with dual therapy, and then triple therapy brought it all the way down. We were not happy being 2/3 down, and this is where part of the motivation that we had of transforming the program from a program that basically says, yes, highly active antiretroviral therapy is here, come and get it, which often means come and get it, and a whole bunch of other obstacles. We decided that we were going to actually bring it and say, here's your antiretroviral therapy, and we're bringing it to you in whatever way suits your needs. And when we did that, you see that the death rate from HIV/AIDS basically collapsed. And by around this time is when we decided to close the AIDS ward, and the rest is history. Notice that all-cause mortality follows the same pattern, always higher because it's AIDS deaths plus whatever other death. And you see here, same pattern, same improvement, but then all of a sudden there is a dissociation between the all-case mortality and the AIDS-related mortality. And this is what's happening now. This is due to the fact that, well, in part, the overdose crisis, but also in part, the fact that our cohort is aging, and therefore they are now increasingly dying from the same things that we will all die one day, which at the end of the day is the best that we can hope for this situation at the present time. The number of people on antiretroviral therapy, triple therapy that is, has grown, as you see here, but notice that it started to plateau. Why? Because the cohort is now starting to shrink. And that's shown by the peak prevalence that we've seen. It plateaus around the 2000s, and more recently started to decline. And more importantly, as you see here, incidence for HIV/AIDS has virtually disappeared. Based on these results, last year in December, Adrian Dix and myself, we basically announced the end of the HIV/AIDS epidemic in British Columbia as an epidemic concern. That doesn't mean that AIDS is over, doesn't mean that HIV is over, and it doesn't mean that it cannot come back. Because as my dad used to say, if you look at tuberculosis profiles in my country region, origin in Argentina, the story is very clear. TB is very high, you invest, it goes down, the investment goes away, so it goes up, and then the investment comes back, and it goes down, and it goes down, and that's public health in back home. Unfortunately, here is the same. And so the difference is that we push hard for the government to understand that that was a potential problem. And by diversifying the program, we kept their interest on the work that we do, and then we were able to continue to support the HIV work. Viviane Diaz-Lima, who is a model with us, she has estimated that we have now seen the peak of the number of people on antiretroviral therapy in British Columbia. And if things don't change, and I will show you how things are changing, now we have entered a plateau, but already have begun to see the declining phase of the epidemic. She estimates with this forecast that the number of people needing antiretroviral therapy in the province of British Columbia is going to decrease by 10% over the next decade, and is going to decrease even faster in the decades to come because of the aging phenomenon that I already described. All along, I was advocating for this notion that highly active antiretroviral therapy basically subtracts people from the donor pool, as I indicated earlier. But to be honest with you, we never been able to show that because we didn't know how to show it. Until in discussions with my good friend Brian Williams, originally from South Africa, from SACIMA, and more recently from Geneva, from WHO and UNH, I learned a lot about the R0 concept and how to use it. And I thought, you know what? I think we can use the effective reproduction number as a tool to understand how treatment is changing the epidemic in our midst and how actually PrEP is contributing to it. So what we did was an interesting analysis that was published in Lancet HIV last July. Again, Viviane led that analysis with a number of others. And what you see here is, well, let me tell you first what the effective reproduction number is for those of you that are not initiated. Well, basically, the R0 is the coefficient that tells us, given a universe of people infected with HIV, how many new infections this group will generate over their lifetime. And so if I have X number of people and the R0 is 1, that means that they're going to generate another group just as the same size as you have. So the R0 of 1 means that the epidemic remains stable. If the R0 is 1.5, it means that it grows by 50%. If the R0 is 0.5, it means that it's declining by 50%. So what you want to do is to bring down the R0 down, and then hopefully keep it down or move it back further down to get rid of your epidemic. So what we did is here in the dark color here, I believe it's blue, we characterized the R0 before highly active antiretroviral therapy became available, 1996, and we see it's at 1.4. That's a very high R0, and that explains why the epidemic is out of control. Treatment becomes available. This is the first phase of the decline of AIDS morbidity and the incidence. And what you see here is that it came down to 1. Well, obviously, that's not good enough because that makes the epidemic stable. As the highly active antiretroviral therapy program becomes more popular and the number of people in treatment increases, the R0 continues to decrease. There are some artifacts here and there, don't worry about that. When we throw in treatment and prevention, then what you can see here is that it continues. And treatment prevention is nothing more than basically strengthening the effort to bring treatment to people that need it. And so if you look at this, with treatment alone, we were able to go from 1.4 to 0.6. That would have been pretty good. But we always want more. So treatment and prevention kicks in down to 0.4. Excellent. This is what happens when you add PrEP. This line continues that, and it declines. So really, it did not change the overall course of the epidemic. Look at that in that way. But there was something very interesting that happened, what we decided was to look at that notion of the people that are suppressed versus the people that are not suppressed. And the good news is that because people are not suppressed, they don't transmit, they have no R0, they have no zero. And then what you're left with is the unsuppressed people, whether you have 200 copies or higher, or unsuppressed over 1,000 and higher. It doesn't matter how you look at it. If you look at the people that are remaining detectable, you see that they are not, did not change one bit. The changes that you see here are trivial given the variability of the number. But look at how interesting. When we actually add an intervention, PrEP, that is not actually focused on the people that take antiretroviral therapy. It's actually focused on the high-risk population. They are not hexanoside. You know why? Let's show you the next slide. We were right all along. Sounds good, eh? So what you have here is a schematic of the people taking, the universe of people taking highly active antiretroviral therapy in the province of British Columbia, illustrated on red. These are all the detectables. Before we come into the program with our treatment, they all transmit. We come in and we basically spread antiretroviral therapy as best as we can. But ideally, I would like to have 100% of people living with HIV on treatment, but it's very difficult to get there. We're still trying. But you can see here, when we did that, basically we covered 95% of the people that are detectable. You saw a huge decrease in the R0, but not so much among the ones that are still detectable. Why? Because they continue to be in contact with high-risk individuals outside of this universe, and these guys are highly susceptible, and therefore they are contracting HIV every day or whatever. So what we did then is we add PrEP, and when we add PrEP, we're basically subtracting from this universe the people at high risk. And what we're doing is, given that these folks and these folks share a social demographic profile for the most part, they're high risk, they probably have contacts through anonymous sources or social media, they probably have multiple partners, blah, 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 the usual thing. Then what you see here is that when you add PrEP here, this completely changes the dynamics, because now the encounter between these guys, the high risk and the ones that remain HIV detectable, are much more infrequent. And so from my perspective, this confirms the notion, number one, that with treatment you subtract people from the donor pool, and with highly targeted PrEP to people at high risk, what you're doing is you're putting a block, a barrier, that even though the red crescent here doesn't know about it, is really protecting them as much as it's protecting the high-risk individuals. However, life is complicated. And as we were celebrating our success in 2022, 2023, by the time in 2024, when all of the administrative training have been done, the number of new infections in the province of British Columbia had gone up from 120 to 186. So I guess I didn't look so good now to the eyes of the minister, right? And by the time we started to study this again, which we are all doing on a full-time basis, to be honest with you, in the first quarter of 2024, there were already 68 cases diagnosed. And if you project out to the rest of the year, this is looking kind of challenging. The numbers are going the wrong way. Now, why would that be? Well, so the first thing we did is we looked at our program. We knew there was something going on here, that it was not the failure of our strategy, but actually something else that was happening. And so we decided to characterize this and see if we could explain the whole thing. What you have here is the number of people on antiretroviral therapy from 1982 to 2023. This is people on highly active antiretroviral therapy. And you see that the number goes for a little while and then comes down. The early enthusiasm in 1996 was tempered with the side effects and multiple doses, etc. That got better when tenofovir and other safer drugs became available. The enthusiasm came back, treatment and prevention kicks in, lots of enthusiasm, and things are working very well. However, on the blue, I'm showing you the number of people that initiate antiretroviral therapy in the province of British Columbia being antiretroviral therapy naive. Oh, these are people that were never been treated. And on the green, I'm showing you people who are actually pre-treated. Now be careful. If you were pre-treated in the province of British Columbia, I know it because we have a monopoly over HIV medication. We pay for it, we distribute it, we monitor it. And so these greens are coming from elsewhere. And what you see here is that as we get better controlling HIV in British Columbia, we have a massive influx of people coming from other regions of the country and the world who already have been treated and they're moving into BC. I don't like to say that we attract them. I hope that they're coming here for other reasons. But nonetheless, that's part of the problem. So Janine Toe, who is the manager of our DTP, the Drug Treatment Program, further this analysis by looking at Paul and others, Rolando, etc., and a large number of people. Look at this analysis, and they're now looking here at the HIV treatment enrollees by treatment experience or ART experience. And you see here, this is the total number of enrollments. And now if you look at treatment experience on the blue and naives on the gray, you see that the gray is coming down and the blues are going up. So this confirms what I just showed you. However, we haven't explored yet what's happening with the naives. And this is what happens with the naives. The antiretroviral therapy naives now, in order to get a handle on whether or not these are local cases or immigrant cases, we ask the question whether at time of diagnosis they had BC coverage. And guess what? These are the total cases of antiretroviral therapy naive enrollees. These are the blues are coming from another province. The IFH are immigrants, and the grays, they have no valid BC MSP. So what is the conclusion? They're immigrants. Now, we don't want to make the whole lot about it. And this is a treatment experience enrollee with non-BC health coverage, the same analysis. The pattern is exactly the same. Other province on the blue, immigrants, refugees, sorry, on the green, and no valid PHN in British Columbia on the gray. The shaded represent extrapolated numbers. But basically, what we're saying is that the epidemic in BC, the domestic epidemic, is over. The problem is that it's not over in the rest of the country. And in case you wanted to be extra sure about this, Jeff Joe, who is in the audience, have done the phylogenetic monitoring for HIV in the province now for as long as we remember. And what you see here is that if we now take the virus of a person infected with HIV, which we do routinely for every virus that we see, no matter where it's coming from, we sequence those viruses to allow us in clinical practice to recommend the best possible treatment to each patient. But then we make a secondary use of those data to create these phylogenetic trees that basically show the degree of relatedness between the various viruses. And then Jeff can reorganize these in a pictorial way, if you want. And what you see here is these clusters. It looks like a bunch of grapes at the time of what's the name of it? Anyways, the point is, what you see here is viruses that are related in these clusters because they are close enough related that we suspect that they are coming from a common ancestor. In other words, my virus matches yours, and matches yours, and matches yours. It may not be that I know any one of my companions here because it could be intermediaries that have not been diagnosed, but we're pretty certain that we are within a cluster, that these viruses are too closely related to be a random event. The colors that you see here belong to the different provinces. Jeff does these for all of the English Canada. We're not going to discuss that in any detail today. Simply want to refer to the BC data. And what Jeff has done here is he demonstrates for us on a semi-log scale the decline of the number of cases associated with clusters and how that declined massively over the last few years. So virtually, what this is saying is we are not seeing reactivation of our clusters in any significant degree in British Columbia. And to illustrate it further, again, this is a new slide that Jeff has shared with me. These are the number of cases now, actually the actual number of cases over the years. This is the total number of cases. And here you see the cluster cases on the red virtually disappearing, even coming into 2024. And the blue cases, non-cluster cases, are going in the wrong direction, starting in 2020. So hopefully that convinces you that, yes, we're okay, except that beyond BC, things are not looking so good. And for that reason, we have crafted these targets that this is during my tenure with the UNH. And basically what we did is we secured the support of the United Nations AIDS program in 2010 to advocate for criminal prevention. But after a number of years of doing this, Michel Sidibe, who was the boss at the UNH, came back and said, look, this is not working. Wherever I go and I tell them that you should be doing in South Africa what Julio is doing in British Columbia, they say, yeah, no, we're doing exactly the same thing. We have treatment, we have diagnostics, we have laboratory, all of this, it's all available. But they don't understand the fact that the important thing is whether or not you roll out these services to the degree that it needs to be done. So I told Michelle, look, don't worry, I'm going to use the BC data to craft a number of metrics that we can use so that people cannot pretend that they're doing treatment prevention, but they are actually start trying to deliver a metric. And through a process of modeling and guesstimation that we did together with Yannick, we came up with the notion that if you wanted to reduce HIV/AIDS-related morbidity, mortality, and transmission by 90% from the global 2010 levels, you would need to have at least 90% of the people living with HIV diagnosed in any given jurisdiction, at least 90% of those on treatment, and at least 90% of them biologically suppressed. That would change the epidemic curve aiming towards 2030, 90% decrease in morbidity, mortality, and transmission. But in order for this to work, by 2025, you have to go up to 95, 95, 95, with the hope that by 2030, you will be approaching 100, 100, 100, which is obviously unattainable, but it's something that it was clear for us from the beginning. We took this to the United Nations and the African Union. It was universally accepted. It became the global strategy for antiretroviral therapy rollout and for the control and elimination of HIV/AIDS by 2030 by the Sustainable Development Goals, and that was very nice. But unfortunately, countries have a way to find a way to do or to pretend that they're doing what they're not doing. And so this is Canada as an example. In 2020, the Public Health Agency of Canada released a report, the status of the role of antiretroviral therapy in Canada, and this is the 1990. Only British Columbia has surpassed the 1990. None of the other provinces has, and the Public Health Agency of Canada, shame on them, concluded that actually we're doing very well. When only one province actually met the 1990 by 2020. PHAC is actually a report to the Minister of Health, which I think is a problem. And what you see here is some further work that we did to clarify this. This is BC, this is the whole epidemic, HIV incidence, and this is the whole epidemic, HIV incidence, different scale, of course, for the rest of the country, excluding British Columbia. Here you see the impact of highly active antiretroviral therapy, here you don't. Why is that? Well, because they're not doing the job. Sorry. So to clarify that, the 90-90-90 was derived from raw numbers that look more like 90% of people living with HIV needed to be diagnosed, 81% of the 100% needed to be in treatment, and 73% should be biologically suppressed. I switched it to 90-90-90 because I thought it was easier to sell. I wish in retrospect that I would have started with 90-80-70, which would have been actually even better. But you learn. And so if you now redraw the same thing using the 90-81-73, it begins to make sense. This is your benchmark. This is BC. We are above, significantly above in all three domains. Northeast, Burley, Ontario, Quebec City are just crossing the boundary, not quite there for the blues, right? So with the blues being under, what happens is you can have 100% for the third, but you're not getting the kind of public health impact that you would like to have. So the notion here is you need to be above 90, 80, 70 if you're going to see this kind of result. The economist has followed the story very closely for a number of years. They have been very supportive and always with a question mark. I think that by now we have convincing evidence that this works, and if properly implemented, it can really change the course of the epidemic dramatically. At the end of the day, our vision is that treatment prevention can lead to targeted disease elimination and result in healthcare sustainability. And what we're trying to do now is to expand the strategy so if there are treatments that are underutilized of any kind, education, prevention, vaccine, whatever, and there are populations that can be identified and studied, you can understand what are the reasons why these two are not meeting optimally and use treatment prevention strategies to make it work. And currently, we're doing so beyond HIV/AIDS for hepatitis C, which has a missing casket of care in the province and in the world. We're doing so for syphilis, gonorrhea, and chlamydia because those epidemics are out of control, and we now have doxycycline that we can offer to people for prevention. And we are, as you know, growing this program very rapidly. We expect that we're going to have positive results in a matter of a few more months. And finally, we're doing this for opioid use disorder in the context of syndemics. Syndemics meaning we recognize that people affected by opioid use disorder are also affected by a variety of other comorbidities, including psychosocial conditions that interact negatively among themselves to worsen outcomes. And as a result of that, we have initiated clinical work and research work in downtown inside a number of years ago, where we're trying to actually optimize a plan to bring treatment to them. So far, we have nearly 2,000 patients enrolled, and the program is working very well. This is the basis of the program, but as I said, this is the subject for another presentation. In the future, we're hoping to expand the role of the center, and in fact, the government has already agreed, assuming that they get back to government, but I don't mind. We'll do it anyways. The idea is to transform the center into a provincial agency responsible for the role of treatment prevention, not just for HIV, but for a variety of both infectious and socially transmittable conditions like COPD, diabetes, or addiction. And hopefully we can contribute to better health, but also savings and protecting our healthcare system. That's it. Thank you.
I think we have just 1 minute for questions. Yeah.
Related to the new cases, supposedly based on immigration, for addressing international immigration, are you considering reducing barriers to enrollment in MSP, or say addressing like immigrants' common knowledge about like being rejected for PR if there's an HIV positive diagnosis? Like, what are the strategies?
So I have good news for you. We offer treatment to everybody and anybody, no matter whether you have MSP or not, as demonstrated by the data. Our program is unique in the country and probably in the world in the fact that we will give people treatment, whether it's antiretroviral therapy for treatment or PrEP, regardless of migratory status.
So is the bigger challenge the initial diagnosis?
Well, maybe, yes, but people that come from the rest of the country often come with an existing diagnosis. People that come from other sources, many of them come with a known diagnosis that have been treated before, and if not, most of the clinics that we work with, they know how to proceed, and we basically just process them as they come.
So they're not like new infections; they're new cases in terms of population numbers.
There are some that are newly discovered, but a large number of them are new to us, but new is not a surprise to them.
I see. Thank you.
I see Dr. Ignashevsky has a question.
Hey, Martha, how are you?
Hey, Julio, I know time is short. I always enjoy listening to you, and I've heard this lecture before, but anytime I hear it, I learn something new. So congratulations on this amazing achievement. But
Thank you,
I'm a
Ali.
cardiologist, and you mentioned number of chronic medical conditions where a treatment as prevention would work. It's, I've been thinking about it a lot. It's a challenging area. I know your Hope to Health strategy is going to be expanded provincially. If you have a 30-second condensed version of how the members of the Department of Medicine could help you to fulfill the goal of treatment as prevention for number of chronic medical condition, please enlighten us.
So thank you, Andy, and thank you also for your support over the years. Anyways, all I would say is that I believe that treatment prevention can be expanded throughout the healthcare system, but it requires that, in addition for you to do your clinical work, that we have a system to use that individual that capture our attention, whether it's with HIV, whether it's with STI, whether with hepatitis C, whether it's with diabetes, whether it's with hypertension, and ask yourself the question, is this condition transmissible? I didn't use the word infectious, I said transmissible. What do I mean by transmissible? Infectious conditions, you understand that. Socially transmissible conditions are basically any disease that has a genetic substrate, a metabolic substrate, a dietary substrate, a behavioral substrate. So if I'm a smoker, my wife will smoke, my brother will smoke, my sibling will smoke. You can use that individual as an index patient as if he was an infectious character. Why? Because you're going to find in his or her immediate contacts people that need your help. And if you identify them early enough, you will be preventing COPD, or you will be preventing nasty complications regarding substance use, etc., etc. Now, do we have those programs? No. But what we're trying to do is build those programs. And the first stage is to show that one program did that and exist, and not only make it happen, but actually was successful. And if I can do that for STIs and diabetes or addictions or smoking, bingo. Then I'm hoping that the healthcare system will realize that we need more doctors, we need more nurses, we need a smarter way of doing medicine. And this is the way to do it. Thank you.
Okay, all right. Well, thank you so much for that amazing presentation. Was actually quite moving and inspiring. Never ceases to amaze me, the amazing work that you've done. Thank you all for attending. I want to invite you all to the next Grand Rounds, which is October 24th, again here in the Hurlburt Auditorium. It's a special presentation by the Endocarditis Working Group, because we all know everything's an infectious disease. But that's another point. Anyways, thanks again for coming, and see you next time.
Hey, how are you? No, I realized that I would, that's what was that. Yes, I am creeping in, and now I kind of escaped the question. It's mainly about that. One guy, two guys. There's one guy that's at City Lodge, and no, I'm yellow. Yellow. He's a drain up. He has a little drain. So he's down. Anyways, he's a bank. Spontaneously. But he wants to go back home and down. And then the other guy, so like,
What days?
Yeah.
Any other retreat?